Welcome everybody. Welcome to the HSMC seminar series. My name is Mark Exworthy and I'm going to chair this afternoon's session. As with our series this year, we've been inviting people who have had a connection with HSMC in the past. And we're really delighted to welcome Dr Alexis Paton from Aston University today. Alexis was HSMC just a few years ago, so has got a very recent current interest in the work that we do, so it's very familiar with the setup that we have here. So we are recording this and we will make this available online. Just to flag, all the other seminars that we have run are available on the HSMC website. Just scroll down to events and you should be able to see the back catalogue there. So Alexis, do you want to share screen while I just introduce you?
Yeah.
It's really good that we've got Alexis to come and talk today on this topic, COVID, inequalities, because of all the seminars that we've run this year, probably this is the most current contemporary one. And as Alexis was just saying before you all joined, that this topic generates a fair amount of debate. So we're really looking forward to having a good discussion this afternoon. Alexis is going to talk for about 40 minutes.
Yep, that's right.
If you would like, please put your comments or questions in the chat. We will use the chat to kickstart the discussion. I'll keep an eye on the chat, but when the time comes, we'll ask people to put their electronic hand up. But in the meantime, could you just make sure that you're on mute? Not except Alexa. Could you not put yourself on mute?
You could do it by interpretive dance, Mark, if that works.
Yeah,
for
that
you.
would be good. Yeah. And with that, thanks very much, Alexis, for joining us today, and over to you.
Thank you. And it's so nice to be back here. So Mark and I were just reminiscing. So I started in August 2015 in my very first full-time postdoc after my PhD at the center, and it's so nice to be back. And it's a pretty decent day outside too. So instead of pretending we're being on our screens, let's pretend that we're sat out in the garden at Park House, enjoying some of that pond and beautiful greenery that we're so lucky to have there. I'm just going to turn my video off while I'm talking to you, just because my internet can sometimes be cranky. But I am here, and I hope you can all still hear me and see my slides, which I am pretty sure it's all there. So today I'm going to talk about fairness in the pandemic. And this has been a really interesting topic, actually, and fairness has sort of hit every aspect of the pandemic. So, COVID-19, it came into our world like this absolute wrecking ball just over 2 years ago. And many have called it the great leveler, but I have to say I disagree. Yes, anyone can get COVID, but how you fare and how well your body actually manages the virus, how easy it is for you to rest and recover, even the underlying conditions with which you face COVID, they're not equal. So what we have is a situation where we've entered into the pandemic on uneven and unequal ground, and some are basically better positioned to survive than others. And despite this inequality, fairness has really grabbed attention in a lot of ways. It's kind of been the word du jour throughout the pandemic. It has been used in policy. It's been trotted out by politicians to justify pandemic measures. And it's been the absolute belle of the ball in the world of medical ethics, where I spend most of my time. But see, the thing is, I think when it comes to health, fair is really a four-letter word. And so today I want to talk about that. And I have a talk in two parts. First, I want to explain why understanding the social and structural determinants of health are so vitally important to understanding the impact that COVID-19 has and will have. And I want to do this because it's effectively a laundry list of reasons of how we as a country and the world have been handling the pandemic in a decidedly unfair way. And then what I'd like to do is I'd like to break down in detail how the focus on fairness in pandemic measures, in guidance and policy has actually created further inequality and greater unfairness in our population. Oh, and I should say, by the way, that I sort of favor pictures over words wherever possible. And in some places, I've added in some art from my very favorite of artists, my mother, Blaine Collins. And this is from a work in progress that she was doing, where she actually embroidered different words across all the days of the first year of the pandemic. And I just love this stay-at-home image that she created. So remember that socioeconomic, cultural, and environmental conditions, they impact on our health. And what I mean by that is where you're born, where you grow up, you live and die, what job you do, how much money you have, where you go to school, your ethnicity, your gender. I think you're kind of getting the picture here. All of these are social and structural determinants of health and illness, and they're a really big part of what makes up our health. And this can come as a surprise to people, though I mean less so to this crowd, I'm sure. But often when we talk about health, we talk about a kind of biomedical model. We talk about viral and bacterial causes of illness, about injuries, about the role of genetics in health. And what we're doing there is we're really focusing on individual causes of health and individual responsibility for good or ill health. But the social and structural determinants of health look beyond that, and they are as important, and I think sometimes almost more so. And in particular, I find these determinants fascinating in the context of the pandemic and how the pandemic is affecting different parts of the population in different ways. So why care about social determinants of health and illness in a pandemic? Surely we should focus on treating patients and just kind of get on with it. I mean, that's certainly been the government's line for just about everything. And well, because certain populations don't do so well in a pandemic, we kind of have to care. And we know this from historical data and retrospective studies from previous pandemics. So I'm talking about things like the original SARS, remember that? Well, H1N1. And in fact, one group in particular do pretty badly, due in large part to social and structural determinants of health and illness. And these are people from ethnic minority backgrounds. So in this first part, I want to focus on this group today in my introduction to fairness in the pandemic, because I think that they are especially beat down by health inequalities, due in large part to systemic and often overt racism that has limited where they can work, go to school, and live through much of history. And when we consider our ethnic minority population here in Britain, I think they're a really good example of what it really means when we say accumulation over a life course when we talk about health. And in particular, when we talk about poor COVID outcomes. Fairness has been in short supply in the history and the health of people from ethnic backgrounds in the UK as well. And across Britain, the rate of death has been disproportionate to the percentage of people from ethnic minority backgrounds, in large part due to the social determinants of health and illness. In some cases, these rates have been more than double the percentage of people from those groups in comparison to the equivalent white populations, which is quite scary to think about. And this has largely come down to where people work and where they live, all of which has influenced, I should say, the development of underlying conditions in these groups. And of course, these underlying conditions, well, they put these groups at greater risk of poor outcomes and death due to COVID-19. Even more sort of disturbing, I should say, is that very often there's a large overlap between a population in deprivation and that same population being from a predominantly ethnic background. And so for the last couple of years, I've been doing a lot of work on how this is broken down, in particular into developed countries with the highest rates and deaths. That's here in the UK and in the US. And I want to compare them both here today to you to really kind of highlight how strongly social determinants impact on health, really regardless of country of origin, and to show how unfairly the impact of COVID-19 is spread across the countries. This is the final version of that work in progress I showed you just a couple slides ago, that's currently on display in London. And one of the things that I find so compelling in this particular piece by my mother is that each of these little sort of red dots, they probably look like red dots to you on the screen, are individual hash marks. And each individual hash mark represents a death from COVID-19 in the UK in the month that that particular piece represents. So 2 years ago, I was pretty sure that this was coming. In April of 2020, in fact, in March of 2020, I was already looking at what was going on and the impact that COVID could have. And I submitted evidence with my colleagues in April 2020 to the UK Parliament on just how badly COVID-19 was impacting on specific groups in the country. It was a real-time, unignorable set of evidence that starkly showed why we needed to consider and care about social determinants when it comes to health emergencies like the current pandemic. It was a big red flag saying, we've only just started and you need to look at this now. And what I'd like to do is I'd like to talk about what some of those concerns were. And I want to do that because they remain the same concerns. And I want to point out that we've known about them for a while now. I also want to take these concerns and compare them to the data in the States. I should say that when I'm talking about this, neither are an example of what to do or not to do. Instead, I want to show some key similarities that speak to how widespread the impact of social determinants are when it comes to looking at health, especially in two countries that are kind of considered paragons of the developed world, and two countries that trade a lot on the narrative of fairness. So very early in the pandemic, data was showing up that healthcare staff from ethnic minority backgrounds were more likely to die from COVID. And then it became clear that patients from ethnic minority backgrounds were getting worse outcomes and also dying in higher numbers. So what we knew then was that COVID was clearly dangerous and deadly if you weren't white. In the UK, this was a really major concern. Over 40% of our doctors and dentists, even more of our nurses, of our healthcare assistants, our porters, are from ethnic minority backgrounds. And the death rates show this. So as early as April 2020, when we were already starting to collect this data, basically 1 month into the pandemic being, you could say, officially declared, already an estimated 64% of COVID-19 related deaths are from healthcare workers from ethnic minority backgrounds. And when you break this down by major professions, it's scary. 71% of nurses, 56% of support staff, and 94% of doctors and dentists who died in that very first month and a bit from COVID-19 were from ethnic minority backgrounds. Since then, these rates have actually continued to always be higher than their white colleagues. But it doesn't just stop there. So workers from ethnic minority backgrounds, well, they're overrepresented in transport, distribution, and retail sectors. And employees from these sectors have continued to work and interact with the public from the get-go throughout the whole of the pandemic. There's been no working at home for these groups. But sadly, in the UK, analysis of COVID-19 related deaths among ethnic minority backgrounds workers from these sectors has remained underdeveloped. But as we're starting to be able to pull some of this data, what we're seeing is that it's likely that there's the same unequal impact that we've already know exists in the healthcare sector. So what we're seeing is that if you were out there and you were working face-to-face and you weren't able to stay at home and you were from an ethnic minority background, you were already in a riskier situation. So of course, this is a problem because what we have is not only are people from ethnic minority backgrounds more exposed to the risk of infection, but they also tend to be in more precarious work and less likely to work from home. Let's look at the kind of stark realities of economics. Employment dictates how much money we have to spend on important things like housing, food, and warmth, all of which, of course, contribute to good or ill health. Excuse me, sorry, I'm just taking a drink. This is my third talk this week. As you lose your job and the likelihood that you end up in ill health, well, of course, that dramatically increases for a population that's already at risk. And additionally, if, like most people from an ethnic background in the States, you were unable to work from home, you are automatically working in a high-risk environment. So over in the States, if we want to have a look at what they were doing, well, only about 20% of Black workers and 16% of Hispanic workers were able to work from home during the height of the pandemic, versus 30% of the equivalent white population in similar jobs and in similar socioeconomic positions. And so in the workplace, people from ethnic minority backgrounds, they've been at greater risk than their equivalent white counterparts. And this is really problematic. And of course, it doesn't just end there. People from ethnic minority backgrounds are more likely to live in densely populated urban areas, where it's more difficult to practice prevention measures such as social distancing to avoid infection. So if we want to look at some of the numbers, 98% of Black minority groups and 97% of Asian minority groups are more likely to live in urban locations than the white population, which sits at only 79%. And this makes them more susceptible to infection than the white population as well. Additionally, it's not where you live, but it's the composition and sort of the actual house itself. So for some ethnic minority groups, household composition makes it very difficult to socially isolate effectively. And this, of course, increases exposures to high doses of the virus. So take, for example, Asian households make up 21% of what ONS calls other households with a multi-generational family. And not only that, but people from ethnic minorities are more likely to live in overcrowded households as well. And we know that the rate of overcrowding for example, Bangladeshi, Pakistani, and Black African households are 30, 16, and 15% respectively. In fact, the rate of overcrowding for all of the ethnic minority groups that we collect data on here in the UK ranges between 3 and 30%. And that's a really big range, but it's still bigger than the whole of all white British households, who sit at only 2% of overcrowding. It's not just that, but we know that also there is existing research that indicates that there is an there is an association between ambient air quality and COVID-19 related deaths. So now we also know that there's an association between area deprivation and ambient air quality. And when we bring all this together, we can take, for example, a recent analysis by Public Health England, which ranked areas of England into deciles deprivation. And they found that 50% of the Pakistani population, 54% of the Bangladeshi population, 45% of the Black African population, and 46% of what ONS calls other Black population. I think they need a much more detailed description of this group, but anyway, lived in areas falling within the 2 most deprived deciles. So what we're getting is that in exploring the relationships between air pollution, socioeconomic characteristics, and ethnicity, we actually find a really dangerous relationship. And this matters because the pandemic measures seem to be premised on an ideal. Everyone has their own room. They've got space to isolate. There's outdoor space to exercise in that's safe. There's the ability to ventilate rooms. Okay, yeah, maybe in Whitehall, but the point is not in Middlesbrough. And as you start to run down the stats and you look at the pandemic measures, a real picture of inequality and unfairness, it starts to emerge. The unfairness is particularly stark when we add in deprivation to the COVID-19 conversation. So I'm sure many of you will have heard the term deprivation discussed alongside the pandemic. Excuse me, not COVID, don't worry. I probably also don't need to tell you that deprivation is a key concept in sociology because it's a key component of society. Deprivation is a fundamental fact of life across the world, across a country, and especially in a city as socioeconomically diverse as our very own Birmingham. Deprivation is the lack of basic necessities like food and shelter. But of course, in Britain, often people are not entirely without basic needs being met. And instead, what we see is that deprivation is often characterized by an instability, meaning people who live in deprivation are often unsure if they'll have basic necessities every month. They're always uncertain whether there'll be enough food, enough heat, enough money to pay rent. And of course, the group that sits in that deprivation is about to get a lot bigger with this current cost of living crisis. Deprivation is only one part of the health story, of course. We've just seen that. But it's one that's come to prominence during the pandemic as health and society really collide, such that the worse off you are going into the pandemic, really the less likely you are to come out unscathed. And a number of social and structural determinants collide and overlap when we look at deprivation, which makes it, I think, a useful lens to consider the social dimensions of COVID in terms of unfairness as well. I think this has been particularly alarming for us social scientists, and at Aston, in my Center for Health and Society, we've been working to raise awareness on this issue, in particular with regard to populations where deprivation combines with the protected characteristics of ethnicity and really creates a perfect storm of poor COVID outcomes. And I always think it's always good to consider what we mean by that in a very real way. So what I wanted to do was talk a little bit more about deprivation and ethnicity. And I wanted to do that looking at Birmingham and the States as well. But let's start with Birmingham. So if we consider deprivation in Birmingham alone, we start to get a better picture of why we need to kind of care about social determinants of health. And we can clearly see there's a lot of health inequality right here in our own backyard. It shouldn't be surprising. Birmingham has high levels of deprivation. So 40% of the Birmingham population live in the 10 most deprived areas in the whole of England. Right? So almost half of our city's population lives in some of the worst deprivation seen in the country. Many areas within Birmingham are amongst not just the most deprived in Birmingham, but the most deprived of all the 4 devolved nations. And so this means we have a lot of people in ill or middling health here in Birmingham as well. And so we have a lot of people in danger of poor outcomes from COVID-19. But it's not just Britain where we're seeing these trends. And I think it's always useful to look around us and see how other people are doing. And when I started poking around other comparable countries and cities, like in the US, I was seeing the exact same thing. In New York, the impact of deprivation on people with ethnic minority backgrounds is similarly stark due to the high levels of concentrated deprivation in the boroughs, which of course makes it a good choice for comparison with Birmingham, which is also a conglomerate of several different neighborhoods, a bit like the NYC boroughs. The US has also been collecting much more specific data than we have here in Britain. And so comparing between the two allows us to look closely at the detailed impact of social determinants of health and extrapolating from the New York data to give us a picture of what is likely happening in Britain because we aren't capturing this type of detail. So what you're seeing here, this is from the NYC COVID dashboard. This has been running throughout the pandemic, and it shows the number of cases, which largely echoes the findings of several studies that, of course, living in deprivation and being from an ethnic minority background means that you're more likely to get COVID. And you can see that in the Bronx, where there is a high level of deprivation, so in the Bronx, 26.4% of residents live below the poverty line, the COVID numbers are the highest across the board, which, by the way, we should pay attention to because the level of poverty in the Bronx is pretty close to the percentage of those in Birmingham who live below the poverty line, which is around 20%. And in Birmingham, we're not doing so great either, actually. We're across most of the key metrics. At any given snapshot in time, Birmingham's doing a lot worse than England as a whole. And that's something that we see really starkly in the New York data. If you look at this particular data about the rates by race and ethnicity, which have been age adjusted, if you're white and living in Manhattan, like, man, do you have it made in the shade. Everywhere else, less so. And in fact, you're pretty screwed over if you're from an ethnic minority background and you're living in any of the other boroughs. And if we look at the Bronx again and compare the numbers of Black Americans who die versus white Americans in Manhattan, it's a shocking 77% increase in deaths. And when I started digging into the different data around Birmingham, we were kind of the same. In fact, we were the first hospital trust to pass 1,000 COVID deaths in the country. And we've always been trending above in terms of ethnic minority deaths as well. So, the situation's dire, that's pretty clear. It's pretty awful if you're poor and Black in the States. It's about as bad in the UK. Why does that matter, other than the knowledge of that? Because the clinical and public health measures that we have to control the virus, or that we had, now that we live in this apparently COVID-free country, I hope you can sense my cynicism and sarcasm, do not take into account the different ways that different populations experience health to begin with. You know, each population entered the pandemic in differing degrees of health and illness. And pandemic measures, of course, to stay at home, as an example, well, they're only safe if you can actually stay at home to work. Home is only safe if you can ventilate rooms, if you can stay away from sick people, if you have good air quality, if you have enough food and heat to stay healthy, if your neighborhood is safe enough to have your windows open, to go out for a walk. Different populations, of course, they have different needs. And as a result, the pandemic is actually widening inequalities and worsening health. And this is when it becomes not just a clinical and a public health issue, but it's an ethical issue too. So considering all we know about the relationship between determinants of health and COVID, let's talk a little bit about the idea of fairness. Fairness to me is kind of the flip side of health inequalities. Fairness has been at the core of COVID policy, showing up in ethical guidance globally, but also clinical guidance for escalation of care in resource-limited situations, which of course was the big buzzword in the first year of the pandemic. And you might wonder how ethics and society can come together. But given everything we know about the social and structural determinants of health and illness, I think it's fair to say that, sorry, that was a totally unintentional pun. I think it's fair to say that certain groups in society did not enter the pandemic on a fair, equal, or level footing as the equivalent white and more affluent populations. So relying on fairness only worsens the existing health inequalities by effectively enshrining them in policy and practice. Sociology has a lot to offer us when thinking about what is ethical or fair. And I think considering the research from sociology can help us get around this problem and develop policy that's truly fair. And so for the next part of my talk, I want to use ethical and clinical guidelines as a case study on why understanding the social dimensions of COVID is just so important. And how sociology can help us make real world impact to create true health equality. So first of all, what do I mean by pandemic ethics before I go any further? Well, pandemic ethics are essentially public health ethics. Unsurprisingly, there are some tensions that exist between public health ethics and clinical ethics, which have different mandates that can come into conflict. Public health is just that. It's about the health of the whole public. And to borrow from Spock, the needs of the many are valued over the needs of the few. Whereas clinical ethics is very often about individual patient needs. And at their core, they consider, all ethical approaches, but actually you can see from the different words that are used to represent these, that they are using and understanding fairness and equality in different ways when they make their arguments. And so this creates a tension that we have to be paying attention to. And then, of course, pandemics present difficult logistical, medical, and ethical challenges to the medical workforce. They require incorporating public health ethics with clinical ethics in some way that at least mitigates these tensions that I was talking about that exist between the two, or at best dissolve them completely so they work together. Though, spoiler alert, I haven't really found that particular approach yet. And as a result, distributive justice is most often cited when looking at ethical principles during a pandemic. But when you delve into that, there's a problem. So previous work done on pandemic ethics has really seen that fairness is how distributive justice is understood and is often touted as that kind of best approach. But fairness is ill-defined. It's often used to show everyone is being treated equally. But the thing is, that's not really fair. If we gave everyone the same thing, treated them in the same way, we see this very often results in inequality. Because, of course, as I've just spent the last 20 odd minutes talking about, different groups in society are disadvantaged compared to others. So instead, what I want to suggest is that equity, meaning that each person is given what is needed to level the playing field, is a better way of grounding ethical decisions. And it's how I think we should understand fairness in the pandemic. Using equity in this way that I'm describing here is actually how I went about writing the ethics guidance that I have done for the Royal Medical Colleges and faculties over the last 2 years. This was the first piece that we ever produced. It was the ethical dimensions for COVID-19 for frontline staff. And you can see that we put that out there right at the very beginning. Over the last 2 years, we've added to it. We've also added appendices on vaccine, mandatory vaccination, and on triage in ambulances. This has been especially pertinent given what we've been hearing about ambulances having to care for patients for several hours. And so I just wanted to be clear that when I'm sort of lambasting the use of fairness by other people in policy and practice, that I am trying as much as I can to put my money where my mouth is. And that's why I think it is possible to do things differently. Unfortunately, not everyone has been so conscientious. As our government developed guidance to tackle COVID-19, of course, the inherent health inequalities that plague our nation, well, they were largely forgotten. Instead, there was this focus on creating fair, objective criteria with which to make the difficult, in quotation, big decisions. This resulted in the development of, and I got to be honest and being charitable here, inadvertently discriminatory guidance and policy that mitigated the virus for really only a select few. To my mind, the big story behind COVID-19 is really how it's laid bare what happens when policy ignores the social and structural determinants of health, and of course the inequalities they create. Okay, so what do I mean by this? Let's talk more concretely. Take, for example, the guidance that is used to determine the priority of care for treatment during pandemics. Well, this is not our first rodeo, right? We've had pandemics before. And research from previous pandemics has found that when decisions are made using only the likelihood of long-term survival and comorbidity, meaning the other illnesses that a patient has, people from ethnic minority backgrounds are disproportionately disadvantaged. And this is because these groups are more likely to have a higher incidence of many of the health conditions used to decide whether critical care is appropriate. For example, people of South Asian background are at a higher risk of heart problems if they come from a deprived background, while richer people in this demographic have a significantly lower incidence of heart disease. Well, this is problematic given that in their information to support decision-making during the pandemic, the National Institute for Health and Care Excellence, NICE, names heart disease as a condition that could be used to determine that a patient should not be escalated for further care. For example, being admitted to ICU with COVID. And this example of heart disease, it really highlights how ethnic minority groups may not receive the same care as white British patients, and shows how existing guidance neglects that relationship that we know exists between ethnicity and health. In fact, this previous work that has been done on guidelines in the pandemic, guidelines, by the way, like those that the UK are currently using, that they developed in 2007 and are still using, in terms of ethics guidance, they've identified this previous research has identified that existing clinical, ethical, and policy guidance actively discriminates against people with disabilities, people from ethnic minority backgrounds, and people from deprived backgrounds too. And to speak to the specific example I just gave, we actually know that social scientific work has shown us that when clinical guidance on escalating care is based on underlying conditions, more people with disabilities of color and poor people die as a result compared to their able-bodied, more affluent white counterparts. In short, fair is really just not fair when it does not account for the reasons why certain populations entered the lockdown in poorer health and with less ability to recover successfully than the other mostly white populations. And as we move forward in the pandemic, it's imperative that we do not create guidance and policy that ignores these concerns. Because let's face it, allowing one group to die for no other reason than their background seems to me the absolute height of unethical practice and resolutely unfair. But this has been difficult to achieve in Britain so far. Several high-profile reports have argued similarly. I'm not a lone voice. and they've been largely ignored. Instead, there continues to be a focus on justice and fairness, but they're not clear about whether they mean equality or equity. And we know 2 years in now that the pandemic has cruelly exposed and exploited the imbalances in our society. It is leaving the deprived, the disabled, and those from ethnic minority backgrounds with more long-term health illnesses, more poor health outcomes, and more dead to bury than any other group. Fairness, as it's been conceived in so much of the guidance, in so many of the blogs and the articles and the policy and the work that comes out of the pandemic, really fails to account for how this version of fairness does not mean equity. And we are blundering through this pandemic in a way that will, at best, leave the marginalized permanently on their knees, and at worst, wipe them out from our society in one distinctly unfair swoop. And it doesn't stop with treating the disease. The idea of fairness has been poisoning our policies to prevent disease too. Let's consider another example of the role of fairness in policy. Let's look at how the UK developed the vaccine priority groups, which have been largely age-based. The JCVI, the Joint Committee on Vaccination and Immunization, and the government COVID task force have been clear that they are aware of the health inequalities in our society. And the JCVI advises not to act to further worsen them. However, there was, and there still is, concern from the social scientific community that in not explicitly acting to mitigate these concerns, and instead choosing to only approach priority groups using mostly age-based criteria, there's a real possibility that the vaccine rollout worsened the health inequalities in our country. And of course, at a time when these inequalities are killing people at an unprecedented rate. So, excuse me, having another drink there. What do I mean by this? Well, an age-based approach was chosen to reduce mortality. It's pretty common, but it failed to account for the nuances between ethnicities. In Britain, people from ethnic minority backgrounds, well, they reached the risk point of mortality from COVID at an earlier age than their white counterparts. So, for example, a Black British man would develop the same risk of mortality from COVID at around age 65, whereas a white man develops this risk at around age 70. Well, that's a big deal because that's a completely different priority group. With the white 70-year-old getting vaccinated several months, if not weeks earlier than the Black 65-year-old who has the same risk. I find this baffling because if the goal is to reduce mortality with our vaccine and booster program, it would only further reduce mortality to vaccinate those most at risk first. And yet there's no evidence of this in either of the policy or the information that's publicly available used to develop our vaccination policies. In fact, reading through the publicly available JCVI documents, it seems that this approach has been largely ignored because medical record keeping has not historically or consistently kept track of ethnicity. This makes it tricky to identify patients who are from ethnic minority backgrounds within the priority groups. The thing is, I'm not so sure it's rather tricky to do is good enough. I mean, it certainly isn't ethical or fair. And determining priority based solely on age-related mortality is not the only way forward. So, for example, several states used the Social Vulnerability Index to develop priority groups in the US, to return to our comparative country. The National Academies of Science, Engineering, and Medicine have developed a framework for allocating the vaccine that tries to account for health inequalities, stating explicitly that the allocation criteria must consider the risk of acquiring infection, severe morbidity and mortality, negative societal impact, and transmitting infection to others. The inclusion of societal impact, combined with the use of the Social Vulnerability Index and the recognition of social determinants of health and illness. So, for example, the inclusion of, in phase 1, people living in overcrowded settings, shows that you can, in fact, have a starring role for equity in big deal ethical decisions like determining who gets the vaccine first. New York is currently operating to this model, or at least one very close to it. As we move out of, I put in quotation marks, the pandemic, countries are less willing to share what they're up to. But I think it'll be really interesting to see how this will pan out in the end when we look back at the health of this population in a few years' time to see if there was any better outcomes here. But of course, it doesn't stop there. While the UK is on its 4th round of immunizations, the newest frontier in unfairness is global vaccine inequity. As high-income countries declare their ability to, quote unquote, live with COVID-19, it's increasingly obvious that money is a key feature in keeping a country safe. Money buys you vaccines to protect your population, and it funds the infrastructure that we need to roll out immunization programs. Of course, far from being the great leveler that I talked about at the beginning, or that I disagreed with at the beginning, the pandemic, I think, is actually just more of the same. It's the great maintainer of status quo. And this is because how the COVID vaccines are being distributed has thrown the idea of fairness just completely out the window. Everything's back to normal. Instead, global vaccine distribution is on a first come, first served basis that is almost wholly dictated by wealth. Once again, the unfair relationship between health and wealth is rearing its head on a global scale. At present, there's an estimated 2.8 billion people globally who remain unvaccinated. And while the jury is, admittedly still out on the exact figures, most vaccines that target communicable diseases require anywhere between 70 and 95% of the population to be vaccinated. COVID-19 is estimated to be in the 70 to 85% range. There's about 8 billion of us on the planet these days, and simple math tells us that we are falling terrifyingly short of the target by about 400 million to 1.6 billion, about 5 to 20%. And while these numbers include skeptics, anti-vaxxers, ineligible children and adults, I think actually what's more telling is not who isn't vaccinated, but of course where they live. We're back to where we started again, but it's just on a global scale. Globally, low-income countries lag seriously behind. Only 14% of people in low-income countries have received a single dose of any COVID-19 vaccine. And efforts to boost these numbers have been really middling at best, fighting against the purchasing power of the high-income countries who are buying and stockpiling vaccines from pharma companies that are manufacturing the vaccines at much faster rates. For example, Pfizer is one of those groups. Low-income countries, well, they've have to rely on basically slower, cheaper sources, either because manufacturing was slower for these companies or because they were reliant on COVAX, which is the global equivalent of a vaccine food bank, using donated vaccines to immunize low-income populations. While a great idea, even COVAX itself admits that to date, it's not been viewed as a success. Excuse me. High-income countries have continually failed to meet their obligations and their pledges. In fact, donating countries have really not covered themselves in glory, donating so much soon-to-expire vaccine a few months back that it prompted the WHO to release in late 2021 the joint statement on dose donations for COVID-19 vaccines to African countries. Catchy title. In this statement, they did not mince their words in reminding donating countries that soon-to-expire vaccines, sent with little notice, did not support COVAX efforts, as many of the relying countries, well, they just don't have the resources to mobilize quickly enough to use doses before they expired. They were clear that this was the very opposite of fair. And despite this policy, donating soon-to-expire vaccine continue. We do it ourselves. So much so that often the vaccines expire before they even make it to the tarmac. And I have to say, I find this really quite baffling because it's not just morally right, not just fair to implement policy that supports COVAX and reduces vaccine inequity. If I'm being really crass, if you run the numbers, it makes fiscal sense too. We are a global economy. We're reliant on global supply chains, especially from low and middle income countries. And the current estimates that we have of the burden of global economic losses on just high income countries, if vaccine inequity and the pandemic persists globally, well, it sits at 13 to a whopping 49%. So our unfair policies are actually hurting us. And recently, a group of researchers estimated that to provide 3 doses of the vaccine to the full populations of low and middle income countries would cost $61.2 billion and avoid 1.5 billion deaths from COVID. It's a steep price tag, I know, But don't forget that the current price tag for economic losses worldwide due to COVID-19 infection stands at 13.8 trillion by 2024. And so the idea that we could have fairness, that we could have global vaccine equity that could be bought for something like 0.4% of the estimated global economic destruction that the virus will cause seems to me like the bargain of the century. You know, the skeptic in me recognizes that these days most decisions are not fair ones, but economic ones. So why aren't we reducing vaccine inequity when it makes so much economic sense? What stands in our way to be globally fair? Well, you know, there is some hope, but an easing of demand in high-income countries is freeing up vaccines for low-income ones. But I think once there, that's where the true battle begins, because there's not an equality of infrastructure globally. But we could act more fairly by implementing policy and supporting the rollout of vaccination is where high-income countries really have to concentrate their efforts to support worldwide economic recovery, and I think act fairly. Many countries lack the infrastructure to administer the vaccines to their population. Some lack the supply chain for the constitutive parts of immunization. Many COVID-19 vaccines require ultra-cold storage that's simply impossible for some low-income countries to provide. And of course, vaccines are worthless if there's no syringes to put in them, no healthcare staff to push the plunger, and they expire in the heat. These are concrete resources that high-income countries can supply to low-income countries so that they can immunize their population in a tailored way to their circumstances. So we don't have to do this. We can be fair and it would actually be better for everybody. But in continuing to practice vaccine nationalism, in turning inward, high-income countries are only hurting themselves and their economy. By supporting worldwide targets of COVID-19 vaccinations in 2022 and beyond, high-income countries can provide that true great leveler to those countries that need it most. And they can pave the way to a stronger, healthier, more economically stable, and this is important, fairer world in 2023 and beyond. I hope that today has really highlighted the many ways that we talk about fairness or use fairness, but how that is actually distinctly unfair. And then, of course, a policy of fairness does not create fair policy. Health inequalities are finally getting the kind of airtime they deserve, and we need to recognize them as major contributors to individual health and well-being. And thinking about how populations experience and come through a pandemic and how that is not equal, and that we need to be looking at the measures that we use to control outbreak in future pandemics that are tailored to the community's needs so that they can be truly fair. If we only do this across the board in guidance, in policy, in measures to mitigate the pandemic, that is how we can actually account for and lessen the impact of health inequalities and inequities in our country.